Okay, welcome back, guys. This is going to be the fourth video of the GI system practice questions. So we'll pick up where we left off. We just finished with spontaneous bacterial peritonitis, and now we'll go to the next question, which is what is a very common cause of mildly elevated LFTs in a patient that is obese, also with hypertriglyceridemia? And what does this progress to? So what is a very common cause of mildly elevated LFTs, that they're obese and hypertriglyceridemia, and what does this progress to? So that's going to be NAFLD, non-alcoholic fatty liver disease, which progresses to NASH, non-alcoholic steatohepatitis. And remember, NAFLD does not yet have pre-malignant potential, but NASH does. So non-alcoholic steatohepatitis has pre-malignant potential. Okay, next question is an idiopathic autoimmune disorder of the intra-hepatic small bile ducts in a middle-aged woman, 30 to 60 years old, with an elevated anti-mitochondrial antibody, importantly, and alk-Phos and GGT. So importantly, woman, 30 to 60, autoimmune disorder, intrahepatic small bile ducts, with an elevated anti-mitochondrial antibody. And we talked about this before. What is the treatment for this condition? Recall what condition has elevated antibodies to smooth muscle, and it's important to know these two. I always get confused between these two, and sometimes they give you a vignette with only the antibodies that you have to figure out. So the answer is going to be PBC, primary biliary cirrhosis, or primary biliary cholangitis, some people call it. The treatment is ursodeoxycholic acid, and that breaks down the bile acids. And this is an autoimmune hepatitis that has smooth muscle antibodies. So again, mitochondrial antibodies for PBC, primary biliary cirrhosis or cholangitis. Treatment, ursodeoxycholic acid, breaks down the bile acids. And what has the elevated smooth muscle antibodies? That's going to be autoimmune hepatitis. And its counterpart, an autoimmune progressive cholestatic disorder of the intra and extrahepatic. So remember, PBC was just intra. So this is intra and extrahepatic ducts, is associated with ulcerative colitis and a P. ANCA, and is more common in men 20 to 40 years old. What is this? What will MRCP show classically on this condition? So remember, the first one, PBC, that was intrahepatic. This one is intra and extrahepatic. And remember, the first one, PBC, was not associated with P. ANCA. It was associated with mitochondrial antibodies. And it was also more common in women 30 to 60, whereas this one's more common in men 20 to 40. So this is going to be primarily sclerosing cholangitis, PSC, primary sclerosing cholangitis. And remember, as we said before, that's associated with ulcerative colitis because both of them have that P. ANCA positivity. And MRCP is going to classically show a beaded appearance of the biliary ducts, a beaded appearance. So that's how we can tell the difference between PSC and PBC. Next patient is a patient that comes in with his family who states he has been having difficulty speaking, dysarthria, and has noticed changes in his personality lately as he is seemingly having delusions. You notice on physical exam that there are abnormal green-brown rings around his cornea. What's the diagnosis? So of course, difficulty speaking, dysarthria, personality changes, delusions, green-brown rings around his cornea. What's that diagnosis? What chromosome is affected in this condition? What chromosome is affected in this condition? How do we make this diagnosis? And what is the treatment for this condition? So this is going to be chromosome 13. This is going to be Wilson's disease, chromosome 13 it affects. And how do we make this diagnosis? It's going to be a decreased serum ceruloplasmin. So decreased serum ceruloplasmin is what binds copper. So it's a genetic disorder with a deficiency of ceruloplasmin. So without ceruloplasmin, we can't bind the copper, and that's going to build up. So it's a copper problem, an overload of copper. And how we treat this is how I remember is TZD6. Some of the treatments in here are trientine, T, zinc, Z, and D-penicillamine with pyridoxine, D6. D-penicillamine with pyridoxine. And the rings in the eyes are those classic Kaiser-Fleischer rings. So Kaiser-Fleischer rings, if you see blue and green halos or circles in the eyes, you want to be thinking of that, as well as the classic symptoms of dysarthria, the difficulty speaking, as well as the personality changes and delusions. So a lot of different CNS symptoms you'll see in Wilson's disease as well. So next one, a patient comes in with a bulge that's painful in what appears to be the scrotum. He states it usually goes away when he lies down and gets larger when he starts to stand, but today it did not go away upon lying down. He has tried to push it back in, but cannot and is in extreme pain. What is this and what is the next step? So importantly, he has tried to push it in, but cannot and is in extreme pain. What is the next step? Also, what is the patho of this condition? What is the pathology of this specific condition? So this is going to be a strangulated inguinal hernia. So strangulated inguinal hernia, it's due to a congenital malformation typically, leading to a patent processus vaginalis, which with an increased abdominal pressure can force the contents through the scrotum, through that inguinal ring there. So increase intra-abdominal pressure can force the contents through that patent inguinal ring, basically, the processus vaginalis. And this requires surgery emergently if incarcerated, or progression to strangulation will be imminent and lead to dead tissue. So incarcerated and then strangulated. Think about it, if you were being strangulated, you have seconds left to live, but if you were being incarcerated, that's bad, which could progress to that, but you still have some time. So this one was incarcerated, he couldn't push it back in, however, it didn't progress yet to strangulation. Either way, that's still a surgical emergency. So next, what is Hesselbach's triangle? So what is Hesselbach's triangle? Important anatomical landmarks to know. And what is the most common hernia in all people? So what is the most common hernia type in all people? Which type of hernia is more commonly seen in women? So Hesselbach's triangle is going to be a direct hernia through the abdominal wall. Within the confines of the triangle is the rectus abdominis medially, the inferior epigastric vessel laterally, and the inguinal ligament inferiorly. So I'll have a picture of that here. Indirect is the most common in all people, but femoral is the most common in women. So even if they ask you and they give you a female and they say, what's the most common hernia for her? It's still going to be indirect. It's just important to know that femoral is more common in women overall. But remember, inguinal indirect is still the most common in all people. And here we have the Hesselbach's triangle. So as you can see, the inferior epigastric vessels right here on that lateral side, lateral superior, the rectus abdominis muscle here in the medial, and then the inguinal ligament or Poupart's ligament down here. And you can see lateral is where that portion of the abdomen, colon, or mesentery enters that inguinal canal, goes through it into the scrotum. And so this patient, they couldn't reduce it back through there manually, so then it's strangulated or incarcerated down here. If they can, and it does reduce spontaneously, that's not incarcerated or strangulated. So that would be the indirect as it goes around Hesselbach's triangle and through, whereas the direct is directly through that Hesselbach's triangle. Next question, what is the preferred diet in gastroenteritis after adequate oral fluid intake is confirmed? So what is that preferred diet? There's a few things that we can give. What is the main side effect one should be wary of about in all antiemetics? So important side effect to be wary of in all antiemetics. What is the mechanism of action of Ondansetron? And what is the mechanism of action of metoclopramide, prochlorperazine, and promethazine? So all three, what is the mechanism of action? And also, importantly, what should we give for metoclopramide, prochlorperazine, and promethazine as well to avoid the dystonic reactions? So that diet that we're going to give is the brat diet, and that's the bananas, rice, applesauce, and toast diet. So a very bland diet for gastroenteritis after we've orally hydrated them. Bananas, rice, applesauce, and toast diet. The side effect we need to look out for in all antiemetics is QT prolongation. So if they already have a near prolonged QT, we want to look out for QT prolongation because it's a side effect of all of them. What is the mechanism of action of Ondansetron? That's going to be block serotonin receptors. And what's the mechanism of action of metoclopramide, prochlorperazine, and promethazine? And that's going to be dopamine inhibition. And what we have to know about this to avoid dystonic reactions is avoiding the extrapyramidal symptoms, dystonic reactions, with adding an anticholinergic. See, when we're blocking the dopamine, we're decreasing the dopamine, and we need to keep a balance between dopamine and acetylcholine. So if we're inhibiting the dopamine, just like in Parkinson's disease before we treat them, we need to also add an anticholinergic too to bring that down as well, else we're going to have those dystonic symptoms, the moving disorders, the tremor, the lip smacking, or anything like that. So to avoid that, we need to also have an anticholinergic to bring down the acetylcholine if we're going to also bring down the dopamine with those 3 medications. And we can use Benadryl for this. Benadryl has anticholinergic properties. We can also use benztropine as well. So again, balance out the loss of dopamine and balance it out with choline, and that helps prevent those dystonic reactions. Okay, so now we need to know the difference, importantly, between invasive and non-invasive diarrhea and the causes of those things. So this is a not favorite topic for me for sure, but invasive versus non-invasive diarrheas. So I'm going to do a list again, just like we did for ulcerative colitis and Crohn's, as well as for ulcers. And we should say if this is invasive or non-invasive. So it's important to study the differences. They might give you a vignette with some of these symptoms. And you should know what the cause is, and how you can know that is based on if it's invasive or non-invasive. Okay, so first one, cytotoxins causing mucosal invasion and cell death. So cytotoxins causing mucosal invasion and cell death, which one is that? Vomiting as the predominant symptom. So which one is more likely to just have vomiting as a predominant symptom? Primarily affecting the large bowel. Which one? Which one typically has a high fever? Which one typically has large voluminous stools? Which one is the small bowel mostly affected? Which one has many small volume stools? Which one has enterotoxins causing GI electrolyte secretion? So which one is enterotoxins as opposed to cytotoxins causing GI electrolyte secretion? Which one will have positive fecal blood, white blood cells, and mucus? Which one is more commonly with Staph aureus? So Staph aureus is more what? Non-invasive or invasive? How about enterohemorrhagic E. coli? Which one is that? Invasive or non-invasive? Salmonella? Which one is that? Invasive or non-invasive? Bacillus cereus? Which one is that? Invasive or non-invasive? Vibrio cholera? Which one is that? Invasive or non-invasive? Shigella? Which one is that? And can you give antimotility meds to? Invasive or non-invasive diarrhea? Which one can you give antimotility meds to? Okay, and now the answers. So cytotoxins causing mucosal invasion and cell death, that's going to be invasive. So remember, cytotoxins causing mucosal invasion and cell death. Vomiting as the predominant symptom is, of course, non-invasive. Primarily the large bowel being affected is invasive. The large bowel. High fever is invasive. Large voluminous stools is non-invasive. The small bowel being mostly affected is non-invasive as well. Many small volume stools, that's going to be invasive. Enterotoxins causing GI electrolyte secretions, that's non-invasive. So think enterotoxins, that's non-invasive, whereas cytotoxins, that's invasive. Positive fecal blood, white blood cells, and mucus, that's invasive. Staph aureus is non-invasive, important to know. Enterohemorrhagic E. coli, that's going to be invasive, and that can lead to that. Hemolytic uremic syndrome. Enterohemorrhagic E. coli, 0157H7, that's that one. Enterohemorrhagic E. coli, important to know, invasive diarrhea. Salmonella, that's going to be invasive as well. Bacillus cereus, that's non-invasive. Vibrio cholera, non-invasive. Shigella, invasive. Shigella is an invasive type of diarrhea. Which one can you give antimotility meds to? And that's non-invasive. So we don't want to give antimotility meds into an invasive diarrhea for sure. Okay, so now we'll go into a few specific causes, and we'll give a short micro vignette, and you'll have to see if you know what type of cause of gastroenteritis this is. So this one is a patient has what seems to be non-invasive gastroenteritis for a few days after returning from a cruise, importantly. What is the likely pathogen? So we already said he's non-invasive, so that's a good clue. It's been only a few days, and he's returning from a cruise. What's that likely pathogen? Next one is an 8-month-old that's been under-immunized. So what type of gastroenteritis vaccine do they get under 2? So 8-month-old, under-immunized. What pathogen might you consider most likely? Next one, after 6 hours of eating food left outside after a picnic of milk, egg, salad sandwiches, Patient comes down with symptoms of non-invasive, importantly, diarrhea. What bug do you want to consider? Remember, food left outside from a picnic of milk, egg, salad sandwiches, non-invasive diarrhea. So first one's going to be norovirus. So you want to be thinking of cruise ship. If you see cruise ship, you want to be thinking of norovirus, like Norwegian. Cruise ship, norovirus is most typically on a cruise ship. The next one's going to be rotavirus. So an 8-month-old that's under-immunized, remember they get rotavirus immunization, the drops in the mouth. That's going to be rotavirus for gastroenteritis at that age. That's under-immunized. And after food that's been left out from a picnic containing any kind of dairy or meat products, and also non-invasive, that's going to be Staph aureus. So next couple, patient ate leftover fried rice from 3 days ago, and now has come down with large voluminous stools. So you remember which type of diarrhea that was, large voluminous stools, that are accompanied by nausea, vomiting, and cramps. What is the likely pathogen? So again, fried rice left out for 3 days and voluminous stools. What's that? What is the classic bug that causes traveler's diarrhea? So which one actually causes traveler's diarrhea? Patient was abroad in many different countries and was drinking from different water sources, which may have had poor sanitation in overcrowded conditions. He is currently appearing profoundly dehydrated and hypovolemic with a blood pressure of 91/49. His stool has rice water appearance, classically, and flecks of gray mucus with a fishy odor. What is this? So very important few things. Poor sanitation. He's really hypovolemic, profoundly dehydrated, rice water appearance, flecks of gray mucus, and a fishy odor. What is that? So first one, Bacillus cereus. So that's classic with fried rice being left out for some time. And that's Bacillus cereus. That's again a non-invasive diarrhea. The classic bug that causes traveler's diarrhea is enterotoxigenic E. coli. And don't get that confused with Giardia. So typically with Giardia lamblia, they give you a patient that's been in a water stream, drinking from a mountain stream, and then they get this protozoal infection, which is Giardia. But this is different. This is just traveler's diarrhea in general. And that's going to be enterotoxigenic E. coli. And also remember, enterotoxigenic E. coli is different from enterohemorrhagic. Remember, enterohemorrhagic is an invasive, whereas enterotoxigenic is a non-invasive. So this traveler's diarrhea is non-invasive, and that's enterotoxigenic E. coli. And classically, we should get this one, hypovolemic, rice water appearance, gray flecks of mucus, and a fishy odor. That's Vibrio cholera. So important to know cholera. Okay, next couple ones. Patient was shucking oysters and then went to eat them after, and now he has necrotizing fasciitis. What is this pathogen? So shucking oysters, ate them, now he has neck fash. What is this? A hospitalized 77-year-old patient for 1 week has been having a condition requiring clindamycin use and now has watery, non-bloody diarrhea. What is this? So hospitalized for a week, they're an older patient, they just used clindamycin and now they're having watery, non-bloody diarrhea. What is this? And what is the treatment for the above condition? So it's really important to know what a couple treatments are for this above condition. A couple more questions about this. What are the complications of this condition? So what's the complication of this condition, this hospitalized 77-year-old with clindamycin use? And what type of precautions are needed in this patient? So that might give it away. What type of precautions do we need to do? So the first one, the shucking oysters in the hot summer months, then eating them after with the necrotizing fasciitis, that's Vibrio vulniferus. Vibrio vulnificus, actually. Vibrio vulnificus. And the next one is C. diff. So remember, after clindamycin, the biggest offender for that, hospitalized, older patient, immunocompromised, you want to be thinking of C. diff. And remember, C. diff is actually a non-invasive diarrhea as well. So that's why they're having those symptoms in C. diff. Treatment for C. diff is oral vancomycin or fidaxomycin, typically fidaxomycin if they've had it multiple times. Oral vancomycin, not IV vancomycin. So oral vancomycin for C. diff. And second line is metronidazole. Metronidazole for C. diff. Complications of C. diff, pseudomembranous colitis, and also toxic megacolon, importantly. The type of precautions we need for C. diff, that's going to be must wash hands with soap and water prior to going in there. So that's contact, of course, precautions. So next one, patient comes in with right lower quadrant pain and admits to eating contaminated pork. She has bloody, small volume, but frequent diarrhea with mucus and a high fever. What is this bacteria? So this is definitely not non-invasive because she's having frequent, small volume diarrhea. It's also bloody, and there's mucus, and she has a high fever. So it seems to be an invasive diarrhea. What is the bacteria causing this? And importantly to note, it's right lower quadrant pain as well, and contaminated pork. Next one, a patient has been having bloody diarrhea and a fever for a week now, and you obtain info from the chart, and it shows treatment was provided with macrolide for a gram-negative S-shaped or comma-shaped bacteria. The patient now is having some paresthesias of the lower extremities, and on physical exam, you know a lack of Achilles reflexes and a stumbling gait. What is this? So again, they were treated with a macrolide, gram-negative, S comma-shaped bacteria. The most important thing that gives it away is paresthesias of the lower extremities on physical exam and a lack of Achilles tendon reflexes with a stumbling gait. What is that? So that's going to be Yersinia enterocolitica with that pork. The first one is going to be Yersinia with that pork consumption. That pork consumption, as well as the right lower quadrant pain that mimics appendicitis, and they can also have mesenteric lymphadenitis as well. So it's important to know right lower quadrant pain mimics appendicitis, mesenteric lymphadenitis after eating contaminated pork. And again, that's an invasive diarrhea for Yersinia. And the next one is going to be Campylobacter Jejuni. So that was a presentation of somebody that was progressing to Guillain-Barré syndrome after Campylobacter. So it's important to know for GBS, Guillain-Barré syndrome, Campylobacter Jejuni, that's a precursor to that condition. And how did we know that? Because they were having some areflexia with the lack of Achilles reflexes. It was ascending from the lower extremities, and they're also starting to have a stumbling gait because of those paresthesias in the lower extremities. Next one, what is a main cause of hemolytic uremic syndrome in children? So what is the main cause of hemolytic uremic syndrome in children, which we already mentioned previously? What antibiotic should be used to be treated in this patient? So how do we treat this? So hemolytic uremic syndrome is enterohemorrhagic E. coli, 0157H7. So that's not enterotoxigenic. Remember, hemolytic uremic syndrome is from enterohemorrhagic E. coli. And what antibiotic? None. So we don't want to use antibiotic in this condition. Do not treat with antibiotics because it results in more risk of hemolytic uremic syndrome symptoms due to release of more Shiga-like toxin. So basically, if we use the antibiotics, we're going to be lysing those bacteria and leading to, they're going to expel more toxins, and that's going to be worse for the patient as opposed to just allowing it to resolve itself. So we definitely don't want to give antibiotics for hemolytic uremic syndrome in enterohemorrhagic E. coli. Okay, so next one. Patient comes in with 1 week since being home from a foreign country. He states there's been a headache, fever, abdominal pain, and an odd bradycardia as well. He notes his diarrhea is green in color and resembles a pea soup appearance. You note on physical exam also a salmon-colored macular rash that spreads, which is identified as rose spots. What is this pathogen? So the few classic things here: rose spots, which is a salmon-colored macular rash, diarrhea of green in color, resembling a pea soup appearance, and a paradoxical bradycardia as well. Okay, next one. A friend has a pet turtle, and after handling it, you forget to wash your hands. A day later, you have severe pea green soup diarrhea that ensues. What is this pathogen? What is the treatment for the above two pathogens? So that's going to be typhoid or enteric fever with Salmonella typhi, which is the first one. So that's that classic rose spots and the classic paradoxical bradycardia for those two things, with also the pea green soup diarrhea. And the second one, after touching the turtle, the reptile, so after touching a reptile, you can also get salmonella, non-typhoidal salmonella. So the non-typhoidal salmonella is typically after handling reptiles, and you have that also severe green pea soup diarrhea. And the treatment for both is fluoroquinolones like ciprofloxacin. So you can do Cipro for both of those. Next one. A patient was drinking from a mountain stream. What do you think of? So right away, maybe the only thing they give you from the vignette is they're drinking from a mountain stream. What is that? What is the treatment for this condition? So it's an important one to know. What is the treatment for Amoebiasis that has progressed to an amoebic liver abscess? So important to know. What is the treatment for Ambibiasis that has progressed to a amoebic liver abscess? And lastly, rhythmic motions of the eye muscles while chewing makes you think of what? So that's kind of a pretty rare one. Rhythmic motions of the eyes while chewing makes you think of what? That's just the classic description. So the first one from a mountain stream, you're thinking of Giardia lamblia. Giardia lamblia. And remember, that's different from traveler's diarrhea, so you have to pay attention to the vignette there. Treatment is metronidazole. Metronidazole. What is the treatment for Ambibiasis that has progressed to an amoebic liver abscess? That's going to be metronidazole, of course, plus paramomycin, which is an intraluminal antiparasitic. So just know paramomycin is an antiparasitic. So paramomycin, antiparasitic. So you remember, just add that if you have a parasite such as Ambibiasis. Whipple's disease. Whipple's disease is the one with rhythmic motions of the eye while chewing. And that's from Trophoremia whipplei. Trophoremia whipplei, in rhythmic motions of the eyes while chewing. Okay, next one. What is an X-linked, males only, recessive enzymatic disorder that causes episodic hemolytic anemia? So now we're going into some of the metabolic disorders in the GI system. So X-linked, males only, not specifically to the GI system, but into this unit of the GI system. Again, an X-linked, males only, recessive enzymatic disorder that causes episodic hemolytic anemia. What medications can cause this condition as well? And what will we see on peripheral smear? What will we see on peripheral smear? What are the most common precipitating factors as well? So it's important to know the precipitating factors and a couple classical things seen on peripheral smear too. So that's going to be G6pd deficiency. G6pd deficiency. And how I remember the meds that lead to this condition or can predispose to it is DNP2. So that's dapsone, nitrofurantoin, and primaquine, and pyrazinamide. So these are some of the few. There's a few more, but how I remember it is DNP2, dapsone, nitrofurantoin, primaquine, and pyrazinamide. On smear, you'll see schistocytes and Heinz bodies. So that's very classic. Schistocytes, also Heinz bodies. The most common precipitating factor, so remember, when they're under stress, this is going to lead to this condition. Infection is the most common. And also important to know, fava beans. Fava beans can cause this too. So infection and fava beans, most common precipitating factors for G6pd deficiency. Okay, next one. A 45-year-old comes in complaining of head pain and progressive hearing disease. Or decrease. So progressive hearing decrease. So again, 45-year-old, head pain, and progressive hearing decrease. There was no trauma. You get a radiograph anyways, and it shows slight enlargement of the skull overall and a cotton wool appearance to the bone itself. What condition are you considering? So again, middle-aged person, head pain, progressive hearing decrease. Radiographs show a slightly enlarged skull overall and a cotton wool appearance to the bone itself. What condition? What might you incidentally find high on labs? So you might find this high on labs before you even do any workup for this condition. What is the first-line medical management of this condition? And what is the most important adverse effect of this treatment to be noted? And what would you advise the patient to do and how to take the medication, for instance? So this is important what to know. This is going to be Paget's disease of the bone. It's abnormal, disorganized, clast and blast, osteoclast and osteoblast formation, leading to problems of the skull that can press upon cranial nerve 8, the vestibulocochlear nerve, disrupting the hearing. So that's why they had that decreased hearing, as well as the head pain. So just a diffuse overall skull pain from the skulls increasing and decreasing with the clast and blast formation. So ALP is going to be increased incidentally with a normal calcium, normal vitamin D, and normal parathyroid hormone as well. So just that increased alk-phos. And remember we said before, if they have a isolated increased alk-phos, then we want to be thinking of other systemic diseases like Paget's disease of the bone. Bisphosphonates is the treatment. Side effects important to know are atypical femur fractures, kind of weird, atypical femur fractures, and also osteonecrosis of the jaw and esophagitis. Advise them to drink plenty of water and to sit up straight for 30 minutes following ingestion. So again, bisphosphonates, atypical femur fractures, most importantly, osteonecrosis of the jaw and esophagitis. Remember, we said that was one of the most important causes of esophagitis. And again, advise them to drink plenty of water and sit up straight for 30 minutes following ingestion. And remember, osteoclasts are the ones that break down the bone, and osteoblasts are the ones that build up the bone. Okay, next one. Patient has a notable hyperkeratosis of the skin all around his body. You also note poor wound healing and recurrent bleeding gums, as well as anemia and glossitis. What vitamin deficiency are you considering? What vitamin deficiency are you considering? Again, hyperkeratosis, poor wound healing and recurrent bleeding gums, and anemia and glossitis. How many months does it take to be deficient in this? So that's going to be ascorbic acid or vitamin C deficiency, and this is scurvy. So scurvy, how you remember it, is the 3 H's: hyperkeratosis, hematologic, and hemorrhages. So hyperkeratosis, hematologic, and hemorrhages for ascorbic acid deficiency, vitamin C, and 3 months it takes you to become deficient. So remember when the people from England were sailing over to the United States, a lot of them got scurvy because they didn't have any vitamin C, any foods with vitamin C on their trip over, and it took over 3 months to get here. So that's going to lead to scurvy, HHH. Vitamin D deficiency in adults is called what? How about in kids? So what is vitamin D deficiency called in adults, and what is it called in kids? Also, what is seen on labs? How about radiographs in osteomalacia? What do we see in radiographs in osteomalacia? What is the decreased osteoid mineralization located anatomically in rickets? So there's an important anatomical location for that decreased osteoid mineralization. What are 3 must-know manifestations of rickets? 3 must-know manifestations of rickets. And what is phosphopenec rickets called? So a few questions about that. So adults is osteomalacia. In kids is called rickets. So in kids, again, rickets, adults, osteomalacia. Labs will show a low vitamin D, of course, calcium and phosphorus, low vitamin D, calcium and phosphorus, an increased parathyroid hormone and alk-phos. So think about it, of course, increased parathyroid hormone. Remember, that's activated to be pumped out when we have low calcium. Osteomalacia will have a looser lines. So osteomalacia will have looser lines on x-ray and pseudo fracture lines. So that's osteomalacia again in adults, and they have looser lines and pseudo fracture lines. In rickets, it's at the physis or growth plate. So that's how you know rickets is in kids. It's at the physis or growth plate. So those are the same thing, the physis and growth plate. Rachitic rosary is important to know, and that's around the costochondral junction in the ribs close to the sternum. Delayed fontanelle closure, you might also know, and genovarum, so that's bow-legged, so legs bowing outwards. And phosphopenec rickets is called Fanconi syndrome, and that's when you're losing the phosphate. Fanconi syndrome for phosphopenec rickets. And again, those 3 classical findings: costochondral junction enlargement, which is rachitic rosary; delayed fontanelle closure, because it is kids in rickets; and genovarum, that bow-legged. Okay, next one. What notable condition does vitamin A excess lead to? What notable condition does vitamin A excess, so an increased amount of vitamin A, link to? How about manifestations of vitamin A deficiency? What will we see in the eyes in vitamin A deficiency? So again, manifestations of vitamin A deficiency. How about vitamin A excess, which we talked about in the neurologic unit? And what will we see in the eye? And the answer to that is going to be intracranial idiopathic hypertension, idiopathic intracranial hypertension, that's pseudotumor cerebri. We're going to see visual changes and night blindness for vitamin A deficiency. Visual changes and night blindness. And classically, the bito spots, white spots in the eyes. And also don't forget it's teratogenic too if excess. So again, if too much, it's teratogenic, and you can have the pseudotumor cerebri. In deficiency, visual changes, especially night blindness, and if severe, bito spots. Next one, what is pellagra? So what is pellagra? How does this come about? So basically, what is the deficiency for pellagra? Pellagra is vitamin B3, niacin deficiency. So pellagra, niacin deficiency, and we have the 3 Ds. So remember the 3 H's for scurvy, vitamin C deficiency. Now we have vitamin B3 deficiency, niacin, and that's the 3 Ds. So that's dermatitis, dementia, and diarrhea. So pellagra is dermatitis, dementia, and diarrhea. Typically, diets high in untreated corn is a risk factor, which leads to a lack of tryptophan. So diets high in untreated corn, which leads to a lack of tryptophan. Next one, a 45-year-old alcoholic comes in stating he's in withdrawal. You start him on IV fluids, 9% normal, 0.9% normal saline with nothing added. What is the risk here? So again, alcoholic, you start him on normal saline, nothing added. What's the risk? What would be a more chronic long-term condition entailing short-term memory loss and then confabulations as a result of this? So short-term memory loss, then confabulations as a result of this. What results from wet beriberi, and how about dry beriberi? So it's important to know a few of these. So if you can put them all together, you'll know what the vitamin deficiency is. Again, dry beriberi, wet beriberi, long-term with short-term memory loss, confabulations, and you gave him only normal saline to an alcoholic. So again, thiamine deficiency, B1, risk of Wernicke's encephalopathy. Wernicke's encephalopathy because of that B1. So you definitely want to give thiamine if you're giving it to an alcoholic that comes into the ER, needs fluids. You want to be giving thiamine to avoid Wernicke's encephalopathy. It manifests as gait ataxia, confusion, and ophthalmoplegia. So gait ataxia, confusion, and ophthalmoplegia, and progress to Korsakoff syndrome. So Korsakoff syndrome or psychosis, which is an irreversible consequence. So again, that Korsakoff syndrome is that short-term memory loss and then confabulations because of that memory loss. So that's Korsakoff syndrome, irreversible consequence of Wernicke's encephalopathy and thiamine deficiency. Wet beriberi, remember in the cardiovascular unit, we talked about it as a cause of dilated cardiomyopathy. So that's wet beriberi leading to the high output heart failure and also due to B1 deficiency. So remember we mentioned thiamine, B1 deficiency, and high output heart failure for dilated cardiomyopathy. And that's wet beriberi. And dry is neurosymptoms. So dry is a thiamine deficiency from neurosymptoms. So how I remember that? Nerves are dry, I guess, and obviously blood is wet. So you're thinking cardiovascular system for wet beriberi and neuro system for dry beriberi. Okay, next one. What deficiency can isoniazid, penicillamine, and alcoholism lead to? Think treatment for Wilson's disease. So that's a clue that we just went over. Think treatment for Wilson's disease. Again, isoniazid, penicillamine, and alcoholism, what can this lead to? B6 pyridoxine. So remember our treatment for Wilson's disease, TZD6, trientine, zinc, D-penicillamine with pyridoxine. So again, a B6 deficiency, which is pyridoxine, can be had from isoniazid, penicillamine, and alcoholism as well. So alcoholism can really affect all the B vitamins, even B12 as well. Next one, PPIs, alcohol, metformin, Crohn's disease, but not ulcerative colitis, gastric bypass, achlorhydria, Selinger-Ellison syndrome, and, which gives it away, vegans are all risk factors for deficiency in what and why? So why are these all risks of deficiency? What is increased in this? That is not in folate deficiency. So what is increased in this specific deficiency that's also not in folate deficiency? There's one specific compound. What will be seen on CBC with smear? A few important pathognomonic findings. What type of symptoms will these patients manifest? And patients with antibodies to the parietal cells need what lifelong in what form? So a few important questions to note here. This is going to be B12 deficiency. Antibodies to the parietal cells that secrete intrinsic factor and absorb in the terminal ileum. So that's why it's Crohn's disease, because Crohn's disease is most common in the terminal ileum as opposed to ulcerative colitis, which is proximal spread from the rectum. Remember, both increase homocysteine, B12 and folic acid deficiency, but only B12 increases MMA, methylmalonic acid. So if you see methylmalonic acid and homocysteine are both increased, then you want to be thinking of B12. I remember that is 1, 2, B12, B1, and 2. So it has two things that increase, whereas folate only has one, and that's just the homocysteine. And again, B12 increases MMA and homocysteine. On smear, you'll see a macro ovalocytes and a macrocytic anemia of over 100 femtoliters as the MCV. So again, on smear, macro ovalocytes and a macrocytic anemia of over 100 femtoliters on smear with MCV. and also hypersegmented neutrophils. So they have all these findings in that B12 iron deficiency anemia. With B12 deficiency, you're going to see peripheral neurosymptoms, most importantly, and B12 takes years to develop, whereas folate just takes months. And what are we going to do in patients with antibodies of the parietal cells, so pernicious anemia, and they need lifelong B12 in what form? So pernicious anemia, we're going to give them IM B12 because that bypasses the GI tract if you're giving an IM, right? So if they have these parietal cell antibodies, again, that's pernicious anemia, they need IM B12 for life every month. And of course, not oral IM because it bypasses the GI tract. Okay, next one. A 35-year-old patient describes pain that is epigastric and radiates to his back, especially when lying down. He refuses to lay down to be examined. The pain is slightly relieved when leaning forward. What are you thinking? So again, some classic physical exam findings here. 35-year-old patient, epigastric, radiates to his back, especially when lying down. Relieved when leaning forward. What is the mnemonic for causes of this condition? So what is the mnemonic? So there's a common mnemonic used for knowing the cause of this condition since there's so many causes. What is the pathophysiology and how does this condition arise? What is the most common cause and the second most common cause? So a few important questions for this condition. That's going to be acute pancreatitis. Acute pancreatitis, and the causes are I get smashed, which helps you understand one of them. So alcohol is one of them. So I get smashed, iatrogenic. G, gallstones, which is the most common cause. ETOH, alcohol, which is the second most common cause. Trauma, T. S, scorpion stings, kind of a rare cause. M, mumps can be a cause as well. A, autoimmune. S, steroids. H, hypertriglyceridemia or calcemia. And remember, the triglycerides, they have to be like over 600 or over 1,000 in this case to cause acute pancreatitis from elevated triglycerides. ERCP can be causing it. And lastly, drugs. So exenatide, which is a GLP-1 for diabetics. HCTZ, hydrochlorothiazide, valproate, and also protease inhibitors, such as those used in HIV. So that's I get smashed as the causes for acute pancreatitis. And what is the patho of this condition, we asked? So that's going to be acinar cell injury due to pre-activation of the pancreatic enzymes within the pancreas itself. So think these enzymes break down fats and carbs, and that's what the tissue is made of the pancreas itself. So it's basically auto-digesting itself. So the enzymes are released before they're supposed to because there's some type of obstruction, commonly due to a gallstone, perhaps. If it's stuck in like the area of the sphincter of Oddi, and then you can't push it out, the pancreatic enzymes are going to activate prematurely and digest the pancreas tissue itself. So that's what's going on there, pre-activation. And gallstones, like we said, are the most common, and alcohol is the second most common. And keep in mind, this is acute pancreatitis, that these are the first and second most common causes, acute pancreatitis. Next one, periumbilical echomosis is called what? And is indicative of what? So periumbilical echomosis. How about flank echomosis? What is that called and what does that indicate? What labs need to be elevated over 3 times the upper normal limit to be diagnostic for this condition? And what is going on with calcium in this condition? So explain a little bit of what's going on with calcium. Like we said, there's hypercalcemia that can cause this, but what's going on with calcium as it progresses? So this is Cullen's sign. Cullen's sign. So remember, a C in Cullen is almost like a circle, so that's around the umbilicus. Gray-Turner sign. We have Gray-Turner sign is if you turn them over on the side, on that flank area, you're going to see hemorrhage. So these are hemorrhagic pancreatitis. These are signs for hemorrhagic pancreatitis. Cullen's sign and Gray-Turner sign for hemorrhagic pancreatitis. What labs are we going to see over 3 times the upper normal limit to be diagnostic? That's going to be amylase and lipase. Lipase is more specific, very importantly. Why? Because amylase is secreted also by the salivary glands too, as you start to break down the carbohydrates in your mouth. So amylase from that, but also lipase more specific because it just comes right from the pancreas. And remember, we don't technically need imaging for this diagnosis. So if we have the classic physical exam findings as well as the lipase and also amylase over 3 times the upper normal limit, we can make that diagnosis without any imaging. And our question, what's going on with calcium? So we said hypercalcemia can potentially cause it, but during acute pancreatitis, we can get a hypocalcemia due to saponification. So what is that? It's when calcium binds to the necrotic fat that has been broken down by the lipase stuck in the pancreas. So remember, we said the pre-activation of those enzymes in the pancreas, lipase being one of those enzymes. So lipase is going to digest that fat, and all that necrotic fat that is starting to digest is going to attract calcium, bind to it, and that's called saponification. And so if we're taking calcium out of the calcium pool of the body, that's going to, of course, leave us with hypocalcemia. And again, leads to the sequestering and low serum calcium. So that's what's going on with calcium in acute pancreatitis. What is the imaging of choice if you do have to get imaging, or if they are not improving after 48 hours? So what is that imaging of choice? So like we said, we don't need it technically for the diagnosis, but if we do get it, what are we going to get? What are the two classic radiographic signs associated with acute pancreatitis? The two classic radiographic signs with acute pancreatitis. What is the overall philosophy of treatment in acute pancreatitis? So kind of a general ideology of how do we treat this condition? What criteria, there's a specific name, is used to determine the prognosis of this condition? The prognosis. So abdominal CT. So that's what we're going to get. That's the test of choice. If we do want to get imaging tests, we're going to get an abdominal CT for acute pancreatitis. What are we going to see? Radiographic signs. It's going to be the colon cutoff sign, and sentinel loop. So colon cutoff sign, don't forget, and sentinel loop. We want to do, overall philosophy is to rest the pancreas. So we want to just give them rest, basically. We want to make them NPO, potentially need an NG tube, lots of IV fluid as it sequesters fluid, and also pain control. Treat the underlying cause. So if they do have a gallbladder, if they do have a gallstone rather, and that's the cause, we want to treat that after they're, of course, stable. If they have hypertriglyceridemia as the cause, then we want to treat that, etc. So no antibiotics unless an abscess does form, which it can. And also Ranson's criteria is used to determine the prognosis, especially after 48 hours. Okay, so I just added this one in because I thought it's important to know the retroperitoneal structures. So I've gotten some questions on that, so I just wanted to add a quick slide in. So how you can remember that one is Sadpuckers, S-A-D-P-U-C-K-E-R-S, Sadpucker. The first one in the retroperitoneal structures. So retroperitoneal, basically back of the peritoneum. That's the suprarenal, so adrenal glands. The aorta and the IVC. Remember, the aorta wraps it around posteriorly, and also the IVC. The duodenum, however, only the second, third, and fourth part. So the first part of the duodenum, as it attaches to the stomach, that's it's still anterior. It's not retroperitoneal yet. The pancreas, except the tail of the pancreas. So the tail of the pancreas pokes back in to the anterior portion, but most of the pancreas is retroperitoneal. The ureters, of course. The kidneys, of course. The kidneys and ureters are very posterior. And also the colon, but the descending and ascending portions only. So the transverse as well as the rectum. Rectum is going to be actually retroperitoneal. So just the transverse portion of the colon is going to be anterior. And the esophagus, the lower 2/3, as it descends, is going to be retroperitoneal. Next one is, what is the most common cause of chronic pancreatitis? So we just went over acute pancreatitis, but how about the most common cause of chronic pancreatitis? What is the classic triad of chronic pancreatitis? That makes sense when we understand what the pancreas does. So what is the classic triad of chronic pancreatitis? So think about what metabolically the pancreas does. How high are amylase and lipase elevated in chronic? Important to know, not in acute. What vitamins do we need to supplement and why? So a few good questions here on chronic pancreatitis. Alcohol is the most common cause of chronic pancreatitis. Gallstones would be hopefully treated by now. So if they're having continual chronic pancreatitis, if it was gallstone pancreatitis, we probably would have gave them a cholecystectomy or done an ERCP or something by now to relieve them of the gallstones. So if they're repeatedly drinking alcohol, that's going to be the most common cause of chronic pancreatitis. The classic triad, think about diabetes signs. So they can't secrete insulin anymore because insulin is secreted from the pancreas. They'll have steatorrhea as well. Remember, steatorrhea, the fat oily stools, because we can't absorb the fat in the from the food, so that's due to our lipase there. That's a lipase problem. And also calcification, so remember the saponification as well. So calcifications are classic, very classic for chronic pancreatitis. on all imaging types too. So if we see calcification around the pancreas, we want to be thinking about that saponification and that chronic pancreatitis. But remember, diabetes, steatorrhea, and calcifications. Those are our go-tos. And the enzymes are not going to be high. They're not even going to be elevated. So amylase and lipase will be upper limit of 3 times, upper limit of normal over 3 times in acute. But in chronic, they're not even going to be elevated. And what do we need to supplement for vitamins? That's going to be A, D, E, and K. And those are fat-soluble vitamins. And why? Because, again, we don't have that lipase to absorb fats, so therefore our fat-soluble vitamin absorption is going to suffer as well. And that's vitamin A, D, E, and K. Next question. Next question is a 67-year-old male that comes in with a history of 30 pack years of smoking. He has a BMI of 39, and he has new onset diabetes and has noticed some weight loss recently. On exam, he has no pain, but you notice some mild yellow skin tinge to his skin and under his eyes and tongue. He further complains about itching that has been getting worse lately. What are you considering? So many signs that give this away. What are you considering? Again, the classic signs. Looks like he has jaundice. He's had weight loss, a long history of smoking, an older male. He has a new onset of diabetes. Why would he have that? He's overweight with a BMI of 39, and he has no pain on exam. Interesting. What are 2 classic physical exam signs you might find? 2 very classic PE signs. What lab marker will be elevated? So a specific lab marker for this condition. What difficult surgical procedure can be done that potentially still might have a decently high mortality rate as well? So what procedure can be done in this case? This is going to be a pancreatic adenocarcinoma. So pancreatic adenocarcinoma, most common in the head of the pancreas. If the tail, it's a later presentation because it doesn't obstruct as well. Think about it. If it's in the head of the pancreas, it might obstruct the biliary tract there, and you might have some jaundice. But if it's in the tail, you're not really going to be seeing any of the effects, maybe just the pancreas itself effects. And the classic signs we should know, those 2 classic physical exam signs are the Courvoisier's sign, which is a palpable non-tender gallbladder. So again, palpable non-tender gallbladder. And also the Trousseau's sign, which is migratory thrombophlebitis. And remember, this is not the Trousseau's of hypocalcemia, which we see that when we inflate the blood pressure cuff, we see the twitching of the hand. So that's Trousseau's sign of hypocalcemia. But this Trousseau's sign in pancreatic adenocarcinoma is going to be migratory thrombophlebitis. What is the lab marker? That's going to be CA19-9, and the Whipple procedure. So the Whipple procedure is a pancreaticoduodenectomy for the procedure, the surgical procedure for this condition. And again, some of the risk factors in the vignette: older male, history of smoking, weight loss, of course, since he has cancer, new onset diabetes, acute pancreas symptoms, new onset of diabetes, yellow tinge, Courvoisier's sign. This is jaundice, and now itching as well. Okay. Next question is a 2-year-old male. So a 2-year-old male presents with painless rectal bleeding and some periumbilical pain. So what is that? A little bit general. 2-year-old male, painless rectal bleeding, and some periumbilical pain. What is the rule of 2s? Which kind of gives it away if you know what the rule of 2s are. And what exactly is the structure that's going on here? What structure is being problematic? So 2 years at presentation, this is going to be Meckel's diverticulum. 2 years at presentation, 2 times more common in males. 2% of the population actually have this. It's within 2 feet of the ileocecal valve, if you stretch out the small intestine. 2 inches in length. 2 types of ectopic tissue. That's going to be gastric and pancreatic tissue as well. And persistent portion, this is the anatomic area, persistent portion of the embryonic vitelline duct, yolk sac, and ophthalmomesenteric duct of the small intestine. So that's the actual anatomic problem that's going on, and it's a residual portion of the embryonic vitelline duct. Okay, next one. Bilious vomiting in a neonate with a chest x-ray that shows a double bubble sign. Makes you think of what? Or an abdominal x-ray. Again, bilious vomiting, neonate, so right after they're born, they have a double bubble sign. What is a double bubble sign? What are the biggest risk factors for this condition? That's going to be duodenal atresia, and polyhydramnios is a risk factor. So polyhydramnios, too much amniotic fluid, and duodenal atresia and that double bubble sign. So think about it, if you're having duodenal atresia, you're going to have a bubble below where that stricture or lack of duodenum is, because it's not even being made atresia. So you're going to have a bubble below that for the distal duodenum and above that, which is the stomach. So that's the double bubble sign. And again, polyhydramnios is the biggest risk factor for this condition. Next one, an older adult comes in with a tympanic abdomen and abdominal pain, distension, and nausea, vomiting. So again, older adult, tympanic abdomen, that's the biggest clue here. Tympanic abdomen, abdominal pain, distension, nausea, vomiting, no history of surgery, and electrolytes are normal, importantly. What is this? Where is this most common to occur in adults, and where is it most common to occur in kids? So if you know what the two differences are, you know what this condition is. So where in adults and where in kids? What is classically seen on abdominal CT? So what is classically seen on abdominal CT in this condition? How about abdominal X-ray? And what is the treatment? So a few things here. Treatment, abdominal X-ray, you're going to see different things than the abdominal CT. And where is it in kids and adults? So this is a volvulus. So volvulus is twisting around the mesenteric attachment site. Mesenteric attachment site is a volvulus. In the adults, it's at the cecum and the sigmoid. And in kids, it's in the ileum and midgut. So you remember rotation of the midgut volvulus for pediatric conditions. So kids is the ileum and the midgut. And adults is the cecum and sigmoid. So remember sigmoid volvulus, cecum volvulus. On CT, we're going to see a bird beak appearance at the volvulus. So a bird beak appearance. Where else did we see a bird beak appearance in the GI system? It's going to be achalasia. So we also saw that in the esophagus, a bird beak appearance of barium. But here on CT, we're going to be seeing a bird beak appearance with a volvulus. Chest X-ray is going to be the classic coffee bean sign. We've seen that. So the classic coffee bean sign. And also the X-ray is going to see a bent inner tube. So they could call it a bent inner tube or a coffee bean sign. I think it looks more like a coffee bean, a large coffee bean in the abdomen. And that's what's going to be seen on abdominal X-ray. Treatment is endoscopic decompression with proctosigmoidoscopy with a rectal tube left in place as they recur often. Surgery potentially if gangrenous. So you may need to actually take out parts of the bowel if they have died off from that constriction, from that twisting around the mesentery, because remember, that's where the blood vessels are coming from, the mesentery. And again, proctosigmoidoscopy with a rectal tube left in place. So you want to keep that thing open with a tube. Next one, important thing to know, which we already went over, I believe. What is a Kerr sign and where is it seen? So what is the Kerr sign and what condition is it seen in? And what is it due to irritation of what nerve? So again, Kerr sign, where is it seen? What is it due to irritation of what nerve? What is the most common cause of a small bowel obstruction? What is the most common cause of a small bowel obstruction? And how about a large bowel obstruction? So what's the most common cause of a small bowel obstruction and then a large bowel obstruction? What is CAVO, C-A-V-O? And these are the 4 hallmark symptoms of this condition. So a few questions here. The Kerr sign is left shoulder scapular pain, left shoulder around the left shoulder and scapula pain, after splenic rupture or laceration due to irritation of the phrenic nerve. So remember, Kerr sign on that left side, that's where the spleen is. And remember, what's the sign on the right side that goes to the shoulder and scapula? Due to irritation of the phrenic nerve. That's going to be in gallbladder. Could be a ruptured gallbladder. And that's going to be Boa's sign to the right shoulder. So left shoulder is Kerr's sign, typically from a splenic rupture or laceration, irritation of the phrenic nerve. Remember, the phrenic nerve goes all the way up, and the phrenic nerve also innervates the diaphragm. So the most common for small bowel obstruction is adhesions, and for large bowel obstruction is malignancy, importantly. So don't forget malignancy for large bowel obstruction, and small bowel obstruction is adhesions, post-surgical adhesions. Crampy abdominal pain, abdominal distension, vomit, and obstipation. So those are your CAVO signs, C-A-V-O. Crampy abdominal pain, abdominal distension, vomit, and obstipation. What will you hear on bowel auscultation in a small bowel obstruction? What will you hear on bowel auscultation in a small bowel obstruction? How about radiographic findings? So what are you going to hear in SBO? That's going to be classic high-pitched tinkles, and visible peristalsis early on, and hypoactive later on. So think about why that would be, visible peristalsis early on. If you're having a small bowel obstruction, the bowel naturally is going to try to push past that obstruction. So that's why you're going to see those powerful visible peristaltic movements early on, because your body's just noticing, okay, there's an obstruction, let me try to push through this. And that's that visible peristalsis early on. And how you hear that is high-pitched tinkles. That's going to be high-pitched tinkles to auscultation. And then later on, it's basically going to give up or not be able to contract anymore, and that's going to be hypoactive. What about the radiographic findings in SBO? That's going to be multiple air fluid levels in a step-ladder appearance. So this is super classic, multiple air fluid levels. Step-ladder appearance, dilated bowel loops with a transition zone. So important to know, a transition zone in air fluid levels in a step-ladder appearance. Next one, what exactly is a paralytic or an adynamic ileus? So what exactly is a paralytic or an adynamic ileus? What are some of the most common etiologies of this? So there's at least 5. What are the most common etiologies in a paralytic or adynamic ileus? How can we differ it from an SBO, small bowel obstruction, on physical exam? So how can we differ this? And what is different on radiographs? So oftentimes you'll have to differentiate between a paralytic adynamic ileus and a small bowel obstruction because they're a little bit similar, but there are a few important things that we can use to differentiate them. So again, paralytic and adynamic, what are the most common etiologies? How do we differ it? And how do we differ it on radiographs? So it's decreased peristalsis of the bowel without a structural obstruction. So like we said in SBO, we're having that high-pitched tinkles, invisible peristaltic movements early on to try to push through that obstruction. But here we don't have an actual physical obstruction. So it's decreased peristalsis without structural obstruction, which can help you give an idea of what would actually cause this. So again, non-mechanical factors that alter the normal coordination and movement of the bowel. Most common for adynamic is, or paralytic ileus, is post-op state. So not necessarily adhesions, but just post-op state where the bowels are still waking up. Opioids, medications that slow it down. Hypokalemia, hypercalcemia, remember, stones, bones, moans, and groans, abdominal groans. Hypercalcemia. Hypothyroidism, or even diabetes, where we kind of lose that innervation over time to the GI tract, and that impairs the coordination of the peristalsis. So that could be even a diabetic neuropathy or a gastropathy, whatever is the nerve innervation to the GI tract. And again, hypercalcemia, how you can remember that is not only that mnemonic, but also hypocalcemia causes twitching and spasms and tetany and stuff like that. So the opposite would be hypercalcemia, so that would slow down things like that. So how do we differ it on physical exam? An adynamic ileus, paralytic ileus from a small bowel obstruction? That's going to be because, again, high-pitched sounds as the peristalsis is trying to push through the obstruction, which we said, whereas adynamic is just as it sounds, not moving, no sounds. So adynamic, just a bowel that's just sitting there. X-ray in paralytic will be dilated with no transition zone. So it's dilated because it's not contracting, but there's no transition zone, whereas as opposed to if there was an obstruction, there'd be a transition zone from before the obstruction, and after the obstruction. And also little to no air as well. Supportive care and treat the underlying cause. So these are the underlying causes we said, name 5. Here's quite a few here. Next one, a 2-year-old male with a past medical history of viral infection 3 weeks ago now has complaints of intermittent abdominal pain, intermittently, of course, that is colicky in nature. His mom says there's been 1 episode of vomit and some scant, bloody, jelly-like stool. You see him attempting to bring his knees to his chest. What is the diagnosis? So classic things here. 2-year-old male, viral infection a few weeks ago, intermittent abdominal pain that's colicky in nature. He's having bloody jelly-like stool, which is classic, and also bringing his knees to his chest a little bit. What is the diagnosis? What are the 2 classic physical exam signs that were not mentioned in this vignette? 2 classic physical exam signs. There's quite a few physical exam signs. What can be seen on the best initial test of this condition? What can be seen on the best initial test? And what is then diagnostic and therapeutic for this patient? So how are we going to treat this? So of course, intussusception. This is intussusception. All the classic signs are there. And again, that's current jelly stools. Current jelly stools. Intussusception, the dance sign is that physical exam sign that was not shown in the vignette. That's an empty right lower quadrant. When you have the upper right lower quadrant, when you're having that intussuscepted piece of bowel that moves up, you're going to have, of course, then some lack of stuff in the lower right lower quadrant because you just moved it basically to the right upper quadrant in the kid. So that's a dance sign, empty right lower quadrant. Sausage-shaped mass in the right upper quadrant, which is why we get the dance sign. So again, the other thing is a sausage-shaped mass in the right upper quadrant. Don't get that confused with the olive-shaped mass in pyloric stenosis. So this is sausage-shaped mass in right upper quadrant. And ultrasound's the best initial test. We can see a donut or a target sign in these patients. So donut or target sign in these patients for ultrasound in intussusception. How is our treatment going to be? It's going to be an air or water contrast enema to decompress the telescoping. So this is really the treatment. Enema of water or air to decompress, to detelescope it. Often monitored inpatient because this can recur very easily. So it can recur very easily, so we need to do this inpatient. Getting towards the end here, a 2-day-old male neonate has been noticed to have abdominal distension and a few episodes of bilious vomiting. There has not been passage of meconium yet. What is this condition? So again, no passage of meconium. He's only 2 days old. Notice abdominal distension and bilious vomit. What is the pathophys of this condition? How does this even arise? And how do we make the definitive diagnosis? So this is Hirschsprung's disease. Hirschsprung's disease is a congenital megacolon due to the absence of ganglionic cells from failure to complete neural crest migration during development. This is Mesner's and Auerbach's plexus of nerves in the distal rectum. Biopsy is definitive. So if we're going to have lack of complete closure in development, we're not going to be having those cells, so it's just going to be stuck shut. And so on physical exam, importantly to know also, if you do a digital rectal exam, you'll note like explosive, basically diarrhea coming out because it's been backed up for so long and it has a shut opening. So you're going to notice that if you do a digital rectal exam. And for Hirschsprung's disease, it's important to know biopsy is definitive diagnosis. And the biopsy is going to show in those aganglionic segments, which is the Mesner's and Auerbach's plexuses. And almost done, 23-year-old woman comes in with periumbilical pain that has now moved to her right lower quadrant. So that has to give it away. Periumbilical pain moved to her right lower quadrant. She endorses nausea, vomiting, and anorexia, classically. What is this? What are the 4 physical exam maneuvers you must know? 4 physical exam maneuvers. What are the 2 most common causes of this condition? So there's 2 proposed most common causes of this condition. And what's the best imaging for a not at-risk adult? For a not at-risk adult, what is the best imaging? And appendicitis is, of course, this. We can see the Rovsing sign, which is when you palpate the left lower quadrant and you get right lower quadrant pain. Rebound tenderness, especially at McBurney's point. McBurney's point is from the ASIS to the umbilicus, 1/3 of the way from the ASIS to the umbilicus. And you can get point tenderness there. You can get rebound tenderness there. McBurney's point, important to know. Obturator sign is if you have an appendix that's kind of malpresented posteriorly a little bit. Obturator sign is when you flex the hip and you bend the knee, and then you're doing internal-external rotation of the hip, and that's going to rub the appendix against some of those internal-external rotators of the hip and cause pain, as well as the psoas sign. So the psoas runs from the spine, thoracic and lumbar spine, down and flexes the hip, connects with the iliacus muscle. So right there, it's going to be touching also potentially the appendix. So if you're if you're letting them off the side of the table and letting their hip fall back and asking them to flex it against resistance, then that's going to irritate the appendix that's next to the psoas muscle there. And then the 2 proposed mechanisms most commonly are fecalith, especially in elderly. If you're having appendicitis in elderly, fecalith, in lymphoid hyperplasia. Lymphoid hyperplasia is the most common. And you can do CT in a not at-risk adult. And so that'll conclude our long review for questions of the GI system. So go ahead and leave some comments, like the video if you like, and subscribe for more content such as this. Thank you for listening, and we'll move on to the next topic.